Good evening. My name is Giorgio Gandaglia. I apologize for my voice tonight. And it's a pleasure for me to welcome you to this UROwebinar on PARP inhibitor in prostate cancer. I'd like to thank the organizing committee for this invitation, and I have the pleasure to attend this UROwebinar with Professor Antonarakis from the US and Professor Nicola Motte. This is our agenda for tonight. We will first discuss about the role of precision medicine in prostate cancer. We will then take a look at when and how to use PARP inhibitors in prostate cancer patients, and we will actually have a practical guide for urologists. And finally, we will discuss about the role of treatment combination with PARP inhibitors. And at the end, we will have 15 minutes for questions and answers. So the first lecture for tonight will be on the role of precision medicine in prostate cancer. I have no conflicts of interest for this presentation. When we talk about precision medicine in prostate cancer, we should first of all have a clear definition. And looking at the FDA website, we can find this definition, which is precision medicine, which is also called as personalized medicine, is an innovative approach to tailoring disease prevention and treatment that takes into account differences in people's genes, environment, and lifestyle. And nowadays, the role of molecular testing and next generation sequencing is actually playing a deep role in the management of our patients. Patients, physicians, researchers can use these gene tests to find genetic variants to help them to diagnose, treat, and to understand more about any diseases, and in particular, prostate cancer. A similar definition is provided by the National Cancer Institute, where here precision medicine is defined as a form of medicine that uses information about a person's own genes or proteins to prevent, diagnose, or treat a disease. We can take together genes, environment, and lifestyle, and then they can be therefore used for prevention, diagnosis, and treatment. And when we have a look at the common spectrum of genetic variants in prostate cancer, we can see that we have typically rare or uncommon high penetrance genes. These are, for example, BRCA1 and 2, ATM, CHEK2, OXB13, and these are genes with a low frequency in the variant population and in the general population, and they confer a higher risk of prostate cancer, and they predict aggressive disease. They should be typically considered individual, and they determine the risk by themselves. On the other end, we have common variants. These variants are, for example, single nucleotide polymorphism. They have a high frequency in the population, they confer a moderate risk of prostate cancer, and they can actually predict aggressiveness only within polygenic risk scores. So they are typically considered within genomic risk scores. So they have a small effect size, they are common, and they should be considered in the context of risk scores, while when we are talking about next generation sequencing, we are talking about rare or uncommon variants with intermediate effect size, which typically confer an increased risk of disease and an increased aggressiveness of prostate cancer by themselves. And we will see this in a second. We should also know the classification for genomic alterations, and we should know that not all variants are actually associated with an increased risk of a disease or with therapeutic, prognostic, or diagnostic consequences. We have, for example, according to the American College of Medical Genetics guidance, pathogenic or likely pathogenic variants, well, these variants should be considered actually for the treatment, prognosis, and diagnosis of our patients. On the other hand, we should be careful because some variants have uncertain significance, and we do not have at the time being enough info to support definitive classification of these variants. When we look, for example, at breast cancer, we can see that approximately 30% of patients undergoing a multi-gene panel for breast cancer actually have a variant of uncertain significance. So the rate of these variants can be high, and actually we can have a change during time. We can expand our knowledge, and the variant which is at the time being of uncertain significance can become pathogenic. When we talk about genetic testing, we should also know that we have germline mutations and somatic mutations. Germline mutations typically occur in gametes and can be passed onto the offspring, and they are present in every single cell of our body. On the other hand, somatic mutations occur in single body cells, and they are typically occurring in prostate cancer cells, for example. They are absent in the gametes, and we can detect them by testing somatic mutations in the tumor specimen. And this is the incidence of germline mutations in prostate cancer. This is a nice cohort of more than 1,300 patients who were actually unselected for family history, stage or of the disease, or age at diagnosis, and all these patients had a personal history of prostate cancer. Up to 17% had positive germline variants, and among them, approximately 1 out of 3 had a variant in BRCA1 or 2. And it is also important to note that approximately 40% of them would not have been considered for genetic testing using the NCCN genetic or familial breast and ovarian guidelines for patients with prostate cancer at the time being, which was 2019. The incidence of germline variants, when we're talking about DNA repair mutation genes, well, the incidence can be as high as 12% in metastatic prostate cancer patients, and 1 out of 2 of them will be a BRCA1 or a BRCA2 mutation. And this was regardless of the presence of a familial history of prostate cancer. Why should we look at these kind of mutations? Why should we as urologists interested in BRCA1 or BRCA2 mutations? Well, they confer an increased risk of prostate cancer, and this is clear. These are data coming from a prospective series where we can see that patients who are BRCA1 or BRCA2 carriers have an increased risk of developing prostate cancer at an earlier age compared to their counterparts who were non-carriers. And this has implications for prostate cancer screening. We can see that men with pathogenic germline variants in BRCA1 or BRCA2 actually can be considered the ideal candidates for systematic prostate cancer screening programs, and the positive predictive value of a prostate biopsy or of the PSA itself is substantially higher in BRCA2 and BRCA1 carriers as compared to control. Of note, also in this prospective series, BRCA2 carriers were diagnosed at a younger age and were more likely to have clinically significant disease compared to non-carriers. The presence of germline mutations has also implications for the management of our patients with localized disease. For example, patients with BRCA1 and BRCA2 mutations or ATM mutations in the germline DNA had a higher risk of reclassification when considered for active surveillance compared to non-carriers. So these patients could be not the ideal candidates for active surveillance. And this slide is just to summarize the current evidence for the role of germline mutations in prostate cancer screening and early stage disease. Guidelines are describing the role of germline testing for men with prostate cancer, and they typically recommend germline testing for men with metastatic prostate cancer or for men with localized prostate cancer on the basis of risk features and family history. We should consider germline testing of BRCA2, BRCA1, and additional DNA repair genes, and we should also consider genetic counseling. When we talk about metastatic patients, we should also consider actionable mutations, and we should also consider somatic testing. This is a nice study on men with metastatic castration-resistant prostate cancer, and we can see that up to 20% of them had aberration of BRCA2, BRCA1, or ATM, and only 8% of them had pathogenic germline alterations. In prospective randomized trials assessing the role of novel therapies in the setting of metastatic castration-resistant prostate cancer, when the somatic testing was available and HRR mutations were tested, we can see that up to 28% of patients, both in the PROPEL and PROFOUND studies, had HRR mutations, and in a substantial number of cases, BRCA1 and BRCA2 were actually mutated. And this is key for the selection of patients who should be considered for novel systemic therapies, such as olaparib, for example. And here you can see at your left how olaparib is actually provides a survival benefit in men with at least one alteration in BRCA1, BRCA2, or ATM. And on the other end, we can see that this is not the case for men with at least one mutation in other 12 genes associated to DNA repair. On the basis of this and other data, olaparib has been approved by EMA in September 2020 for the treatment of patients with metastatic castration-resistant prostate cancer who are BRCA1 or BRCA2 mutated. And here you can see that even when we're treating patients with a combination of novel ARTA plus olaparib, the effect is higher in men who have HRR mutation compared to the ones who are non-HRR mutated. You should also remember the role of microsatellite light instability and MRD tumor mutation. So patients with a mismatch repair gene deficiency, actually, they can be considered, according to the FDA, for other systemic therapies, such as pembrolizumab. And this is a nice study demonstrating that pembrolizumab has anti-tumor activity in the context of patients with metastatic castration-resistant prostate cancer, based on the presence of MSI or MMRD tumors. We can actually consider pembrolizumab. However, please note that only 2% of our patients in the setting of metastatic castration-resistant prostate cancer are mutated in these genes or have microsatellite instability. And finally, I would like to show you some data regarding an earlier setting, which is hormone-sensitive metastatic prostate cancer. In this setting, we have data coming from the REAL and STORM trial, which have been recently published by the Journal of Clinical Oncology, and here patients were stratified according to the presence of pathogenic somatic mutations in ATM, BRCA1, 2, RB1, or TP53. And at a median follow-up of approximately 5 years, we can see that patients with mutation in these genes actually were the ones with the largest benefit of metastasis-directed therapy compared to the ones without mutations. So the presence of mutations in HRR can actually be used also in an earlier setting to identify candidates, for example, for metastasis-directed therapies. And again, BRCA1, BRCA2, ATM, DNA mismatch repair deficiency or other DNA repair genes should be used to guide the management of metastatic prostate cancer patients in precision medicine. And these are the guidelines for somatic testing in metastatic patients. Our guidelines, the EAU guidelines, currently recommend to test patients with metastatic castration-resistant disease. And the NCCN guidelines provide a broader classification, and they actually recommend to test all metastatic patients, and they also recommend to use the metastatic biopsy, or if not available, plasma circulating tumor DNA. And these are the genes that should be tested again. This is a nice graph from the position paper of Italian scientific societies summarizing what to do with a patient with a metastatic prostate cancer. And well, we should first of all consider somatic testing, and if it is positive, we should consider germline analysis on peripheral blood, and this will actually guide screening and genetic counseling. And on the other hand, the presence of mutations can guide the administration of PARP inhibitors, for example. On the other hand, we should also remember that somatic testing cannot be enough, and this is a nice study recently published where 100 men underwent both germline testing and tumor-only sequencing. Well, tumor-only sequencing failed to report the presence of pathogenic germline variants in up to 20% of the patients. And therefore, ideally, both germline testing and somatic sequencing should be considered in these patients. Finally, I'd like to conclude my talk with these take-home messages. Precision medicine is already an option for the management of prostate cancer patients. Urologists should be aware of the importance of genetic testing and the use of next-generation sequencing to identify homologous recombination repair genes mutations should be used again to identify the candidates for a more intensive prostate cancer screening and should guide the management of localized disease. For example, these patients cannot be the ideal candidates for active surveillance. And these genes, together with mismatch repair deficiency and microsatellite instability, should guide the delivery of targeted therapies in the setting of metastatic castration-resistant prostate cancer, and potentially could guide the delivery of targeted therapy even in patients with hormone-sensitive metastatic disease. I'd like to thank you for your attention, and I'd like to introduce the next talk by Professor Nicolas Motet.
Thank you, Giorgio. Good evening, everyone. So, when and how to use PARP inhibitors in prostate cancer? I'll try to be practical. My disclosures. So, we know there are 5 pathways involved in metastatic CRPC. The AR-targeted pathway is absolutely well known, and now we have this one to consider, and this one I will discuss. Just want to highlight 2 things. It's all what I will show you is based on trials. And now we have available one large randomized controlled trial, you know it. And as you know, there's one drug that is EMA approved. And there's a second drug that is also FDA approved, as well in Europe, or is mostly focused on the one approved in Europe. The rationale for that, if you had listened to the previous talks on this series, you know that the rationale to use a PARP inhibitor is as follows. In a normal cell, you have 2 things that are able to repair DNA damage, one through PARP1 and one through BRCA. Let's go that way. If you have a defect in BRCA pathway, the PARP1 is still working, and so the repair is corrected. If you have the other way around, if you block the PARP1 by a drug, in a patient who otherwise has a normal BRCA pathway, the cell will also be repaired. But if by chance you target a patient who has a BRCA abnormality, that is a BRCA pathway that is no longer working, and you block the PARP1 pathway with a PARP inhibitor, suddenly there's no longer any DNA repair possibility, and the cell is pushed to death. That is, very simply said, the rationale to use PARP inhibitors in BRCA deficient patients. Giorgio clearly showed that you have 2 totally different things: the somatic DRD abnormalities. Somatic means they are only present in tumor cells, They are linked mostly to mutations that occur during the disease progression that might be also induced by the treatment itself. And at the end, this pathway, which is purely limited to tumor cells, might be the driving one. Completely different is the germline testing, is the germline pathway, where the cells are constitutively modified. That means that your children, your brother, your uncles might or not have these abnormalities. There are a lot of several genes that are potentially involved. BRCA for sure, ATM for sure, but you have here a list of some of them, and the list is much longer than that. And you will show why I insist on that. So the first question is, okay, we need to find and to select the patient who have these mutations. Practically, how do we do it? Three simple messages. The first one is probably the most important one. We should be very careful and only use a validated assay. Be very careful if you use an in-house next generation sequencing. There are several papers that suggest that this next generation sequencing done in-house might give you quite different results. So probably a validated assay is clearly the way to go. Second, you have two ways to approach this. Either through a tissue. An example of this tissue assay is the one that was used in Profound, the Foundation One test. It's a companion test. It's not mandatory, but it's a clear example of what can be done. So if you have tissue, it means you have a biopsy or the full specimen. With the whole specimen, you must remember that there is a time limit. Do not even think to use the radical prostatectomy specimen that was taken out 20 years ago. Clearly, it won't work. Giorgio suggested that based on Italian guidelines, it's up to 6 years. Well, there are some other situations where it might be less than 5 years, but at least up to 5 years, that's correct to try. Beyond 5 years, probably it's not correct to try, and you need to biopsy. And then the question is, where do you do biopsy? Most of these men have bone metastases. Unfortunately, that's probably the least target you should consider. There's a major issues when you use bone metastases, especially that they need to be decalcified, and this might completely change the results. So ideally, it should be either nodal disease, the prostate itself, of visceral metastasis. And it is an aggressive procedure. The second thing, if you target a MET, you might target, we all know that the METs are a little bit heterogeneous. And you might, by chance, in multiple brackets, target a lesion where the abnormality is not present. So this is a potential limit of tissue sampling. The other way is to go for blood sampling using cell-free or tumor-free DNA. It's easier. The rationale is that these cells have a lot of tumor DNA in the blood. It's much more patient-friendly. Having a visual targeted biopsy or just a blood sample, no need to discuss. It's available. We have some trials for that. We have some validated methods to check them. The issue is they have also limitations. And the major risk is to have false positive through somebody which is named CHIP. CHIP meaning a clonal hematopoiesis of undetermined potential. So if the blood test is positive, the older the patient, the higher the risk. It's a false positive. And this is so far one of the major issues with liquid biopsy compared to tissue biopsy, but it's validated. All the story started with Johan de Bono's team, as often in prostate. He had a small phase 2 trial using olaparib in 50 metastatic CRPC patients, and he He reported the outcome based on the fact that patients had or not a DNA repair pathway abnormality. You have here the list of all over there, and there was a clear difference in radiographic progression-free survival and a very clear trend for overall survival favoring the outcome with olaparib when the patient had these biomarkers abnormality. Based on that, the PROfound trial was launched. I just want to focus a little bit on this trial to highlight several things. It's a prospective randomized controlled trial. All the patients have an mCRPC. They all had been previously treated with an ARTA, either ABI or ENZA. Docetaxel was allowed, but roughly half of the patients did not receive docetaxel upfront. And the patient was stratified based on two cohorts. Cohort A was only patients with BRCA1, 2, and ATM. Cohort B, any other mutations. If the patients had no mutation at all, they were not included. The primary objective of this trial was a radiographic progression-free survival for cohort A. Cohort B was mostly experimental, investigational, and overall survival was a key secondary endpoint. You already saw the results. Radiographic progression-free survival, no need to discuss for cohort A, a huge difference. That's fine, but pain-free survival is also there, probably more relevant for patients. Clear, huge difference between olaparib versus control for those men, again, from cohort A. Even better, overall survival, which is a secondary objective, was also achieved with a favorable outcome despite crossover, and crossover was not trivial. It was up to 67%. If you remove the crossover patients, the results are even more impressive. So clearly for cohort A, that is BRCA1, 2, and ATM, it works. It doesn't work. At least it doesn't seem to work that well for those men from cohort B. As a cohort B, radiographic progression-free survival, absolutely no difference. Overall survival, no difference at all. Even worse, if Johan de Bono last ASCO GU 2021 also considered the results based on BRCA1, BRCA2, and ATM. If you remember, this belongs to the cohort A group. And for ATM, results are quite disappointing. Radiographic progression-free survival, not significant. Overall survival, not significant. This is the reason why for EMA, olaparib is only approved for BRCA1 and BRCA2, despite the fact that ATM was included in the group A. Is everything so clear? Even worse, even worse. Have a look at the control arm. Patients that ought to have received either ABI or ENZA, and the control arm was the drug that was not used before. Reusing such a drug, we know that it's not probably the best way to go. The previous use of docetaxel, you have it here. The previous use of combination therapy with 2 chemo, it's here. And it's probably not so trivial, because if you go for stratification based on the outcome, based on the fact that patient already received a taxane or not, suddenly there is a huge difference for those who already received a taxane and for those who did not. For EMA, olaparib does not need to occur after a taxane. You will see that it's not exactly the same with the other PARP inhibitors. But olaparib has a toxicity, and it's clearly not a trivial drug. As a whole, the most frequent toxicity is anemia. If you have a look in terms of anemia, nausea, fatigue and asthenia, decreased appetite, etc., clearly there's an increased risk, all grade, compared to the control group. You might say, okay, but what about severe side effects? Well, severe side effects, 23% grade 3 and above anemia, 2% grade 3 and above nausea, compared to 5% and 0% in the control arm. Even worse, treatment stop because of side effects, 46% compared to 19%. 23% dose reduction based on side effects compared to 5%. treatment temporarily stops because of side effects, 20% compared to 8%. So the drug is effective, but it's not a trivial drug. Toxicity is a real issue. Olaparib, as I said, is not the only one. We have others. Niraparib, rucaparib, talazoparib, so far, and veliparib. They are not exactly the same drug. You cannot jump from one compound to another one. And just to highlight things, rucaparib is approved by FDA, to my knowledge, based on a phase 2 trial, the TRITON-2, 115 metastatic CRPC patients, all of them following docetaxel and Narta. The objective response rate is roughly 51%. That was the primary objective. Toxicity exists. Niraparib, just published the Galahad trial, 289 patients with metastatic CRPC, all treated with at least one taxane and one ARTA, always at least GRD abnormality. Again, objective response rate, 34%. If you only check for the measurable disease, 5% objective response rate. So clearly, these PARP inhibitors work. The labeling is a little bit different, but again, olaparib does not require docetaxel first. The toxicity from niraparib, again, significant. And suddenly we have this trial. I show it to you very quickly. We already said so far is that this drug works if you have a GRD abnormality. PROPEL is a prospective randomized controlled trial, first line in CRPC patients. Patients might have received docetaxel when they were castrate sensitive. They all failing after they have never received abiraterone, and they are randomized between abi plus olaparib versus abi plus placebo, irrespective of DRD abnormality. And the primary objective of this trial is radiographic progression-free survival. Emmanuel will detail this trial, and that's the result of the trial. The radiographic progression-free survival, which is the primary objective, there's a very clear trend for the combination compared to the abi monotherapy, irrespective of DRD abnormality, which is at least a little bit surprising. But be very careful. So far, we have absolutely no survival benefit. And even when we consider the last update of this trial that was presented a few weeks ago by Noel Clark at ESMO, absolutely no survival benefit yet. So, germline somatic mutation, they must be checked. I will reinsist, germline, it's major for the man and his family. No need again to highlight that. It's important to have that because for the man, it might change the way we treat, it changes the treatment, it might also change a little bit the drug we're using outside the PARP. And this is a guideline position where to check for germline. But PARP inhibitors are not restricted to patients with germline. They are there for every man with a BRCA mutation so far. Therefore, olaparib, which is the only drug available in Europe, there are no absolute contraindication in prostate cancer. It's a strong word of caution if you have a very severe renal or hepatic insufficiency. There are a lot of drug interactions, and as usual, we are dealing with very often old men. So clearly, drug reconciliation is absolutely needed. And probably the most important thing during the therapy, treatment monitoring is absolutely needed, and a monthly blood test for a year is absolutely needed. Remember the roughly 23% grade 3 and above anemia that you might have with the olaparib. So it's clearly a major adjunct to our armamentarium. It seems to clearly to improve the overall survival, despite some issue with the trials, after at least one ARTA, but only if the patients have a proven BRCA1 or 2 abnormality, and it's again only available in Europe for this and not for ATS. With this, I conclude here, and I will give the mic to Emmanuel Antoniorakis, who will elaborate a little bit about the triplets and the combination of the drugs.
Thank you, Giorgio and Nicolas, for the introductions. And I'm going to talk about combination therapies with PARP inhibitors. Those are my disclosures. First, I'm going to talk about 2 slides about the rationale. First of all, we know that there is a limited number of patients that can receive the PARP inhibitor monotherapy. So can we expand beyond the BRCA2 patients? Secondly, we know that resistance to monotherapy exists, even in patients with BRCA2. The ones that respond often develop a secondary resistance. And then there's some preclinical evidence that even in the absence of DDR mutations, the combination of an AR inhibitor and a PARP inhibitor might make sense. There's 2 reasons for this. The first reason is that the androgen receptor indirectly regulates many of the DNA repair genes, including RAD51, BRCA1, and BRCA2. So if you inhibit AR, you can inhibit the transcription of some of those genes, inducing a BRCAness. And secondly, it turns out that PARP itself is a pioneering factor for AR. Pioneer factor means an epigenetic regulator of AR transcriptional activity. So by decreasing PARP1 using a therapeutic drug, you can indirectly decrease AR transcription as well. But of course, all of us on this call are clinicians. So do these preclinical rationale translate into a clinical efficacy? Let's see. So first one is the PROPEL study. Nicolas presented this one briefly. This was a study with unselected first-line mCRPC patients. Interestingly, the gene status was not used as a stratification at all, but it was evaluated post hoc after the fact. And as the study was designed, it was a positive study. I would say there was a clinically significant and statistically significant improvement in progression-free survival with combined abiraterone olaparib versus abiraterone alone. And interestingly enough, in the patients with homologous recombination mutations, the benefit was greater, with the hazard ratio becoming even better, 0.5. But even in the patients without homologous recombination mutations, there appeared to be a benefit in this post hoc analysis, with the upper limit of confidence interval not including 1.0. So you might hypothesize that perhaps there truly is a synergy between AR inhibitors and PARP inhibitors, even without requiring homologous recombination mutation. As was mentioned, the overall survival is not yet mature. This was updated at ESMO with 40% maturity. Still, we don't have a positive result, although there is a slight separation of the curves after about 20 or 22 months. And the final overall survival analysis is still pending. Of course, the drug has toxicities as monotherapy, and some of these toxicities are compounded when you add abiraterone. So the ones in red are the ones that I thought were the most significant: anemia, nausea, anorexia, and also a 6 to 7% risk of venous thrombosis, including pulmonary embolism, which was higher than the control group. Now, the magnitude study had a different design. Here we were looking at the combination of niraparib plus abiraterone versus abiraterone. Here, this was a biomarker stratified study. So all patients had to have the NGS analysis before randomization, and they were stratified into biomarker negative and biomarker positive groups separately. The biomarker negative subset was not significant, and this cohort was closed early after an interim analysis for futility. And the biomarker positive population did show a progression-free survival advantage. It was relatively modest, but statistically significant. And if you focus in on the BRCA1 and BRCA2 patients specifically, the progression-free survival advantage was greater, with a hazard ratio that was lower, approximately 0.53. Now, the overall survival with magnitude is also very immature. Perhaps no signal yet, but we do not know. With more time, signal might emerge. Here, there are some toxicities as well. There was more thrombocytopenia with this combination. There was also an interesting signal for worsening arrhythmias. I think that could be of concern, as well as potential cerebrovascular complications, 3% versus 1%. Now, we are always told we should never do trial comparisons. So this is heresy, but this is my figure. I'm allowed to do it. I made this myself. Please don't use this if you don't believe my conclusions. But what I try to do is I try to compare the hazard ratios for PFS benefit in the three groups of patients: HRR wild type, HRR mutated, and then BRCA1/2 mutated. In each case, the red is the magnitude, the green is the propel, and you can draw your own conclusion which of these combinations you think is more effective. In my opinion, it's the olaparib plus abiraterone. And so if I had the choice of using both combinations, probably I would favor the olaparib abiraterone. Right now, neither of those is approved by the FDA or the EMA in combination, so it's still considered experimental use, should not be used in routine clinical practice yet. There are two other studies. One of them is talazoparib plus enzalutamide, the TelePro-2 study, and another one with rucaparib plus enzalutamide. Neither of those two studies has results yet, and probably we have to wait at least 12 more months, maybe even longer, for the CASPAR study to read out. But these studies could be a tiebreaker if you are not sure whether there is a benefit of combination therapy. I also want to point out there are other combinations being explored, not just AR therapy plus PARP inhibitor. There are combinations with immunotherapies, radionuclides, angiogenesis inhibitor, and others. One that I would like to point out was presented at ESMO 2 weeks ago by my colleague, Evan Yu. This was the phase 3 study combination of olaparib plus pembrolizumab. There was a lot of enthusiasm about this study. Unfortunately, for those of you that were in Paris, it was a negative study. In this trial, patients with metastatic CRPC were randomized to the combination of pembrolizumab plus olaparib versus the alternative AR therapy. This was not a biomarker-selected population. So unselected patients, the genomic analysis was done in a post hoc fashion, and the study was negative for its primary endpoint PFS. However, if this study had been designed in BRCA1/2 patients, it would have been positive. The very significant post hoc exploratory analysis in the BRCA1/2 patients, and overall survival, no difference whatsoever. However, once again, in the BRCA1/2 subset, this would have been positive with an upper limit of hazard ratio 0.99. Of course, this study was not designed to test the hypothesis in the BRCA1/2 patients. So in conclusion, we have two randomized phase 3 studies showing potential benefit of combination AR inhibitor plus PARP inhibitor. They have some significant differences. In the olaparib abiraterone combination, there might be an unselected difference in all-comer population, while in the magnitude study, niraparib plus abiraterone may only be efficacious in the homologous recombination positive patients. Thank you very much, and we are ready for your questions.
Thank you, Emmanuel, and it was actually a great talk, and thank you, Nicola. I have a first question for you, and I invite everyone to type your question using the Q&A function in Zoom. And my first question relates to the potential role of these therapies in earlier setting in prostate cancer. So we see now that the data are there for the metastatic castration-resistant setting, and we know that many of these mutations are actually present at the level of the tumor while it develops. So we know that when we look at the germline data, approximately 5% of our patients are BRCA1 or BRCA2 mutated in well-defined and selected settings. So probably not all these patients will benefit in an earlier setting for these systemic therapies at least. So do you see a role for them? And the question is both for Nicolas and Emmanuel in an earlier setting compared to metastatic castration-resistant patients?
Emmanuel, maybe you answer first.
Well, I think we have to distinguish research versus clinical use. In clinical use, we don't have in Europe or the US an indication for any PARP inhibitor in that setting. So although I do it in my academic, ivory tower, I don't think it should be routinely done yet in clinical practice.
Yeah, I couldn't agree more on that. It might be of interest. We know that the patients will carry a BRCA1 mutation, have a more aggressive disease, even if it's localized. We don't know what to do with this. It's more aggressive. Does it mean that we completely need to change our management? Maybe. Immediately or later on, nobody knows. The cost of that in terms of side effects is absolutely unknown, as is the benefit, if any. So, as Manuel said, it's purely research, and it should be done in research, but should not be done in practice. If you allow me to comment on one of your point, Giorgio, I partly disagree with what you say regarding active surveillance as BRCA. If you carry on a BRCA1 mutation, by no means it means you should not go for active surveillance. It only means that you need to be careful. All what is showed is based on one single paper with less than 40 cases, and the primary objective of it was just reclassification. By no means it was something more than reclassification. And reclassification per se is not equivalent to you must not go for active surveillance. It just means you must be aware that during follow-up you have a highest chance to be in need for an active therapy. That's probably different.
I completely agree with you. I stated that BRCA mutated patients could not be the ideal candidates, but I agree that we can consider active surveillance. What we do in our practice in the presence of family history, we typically test these patients also if they are candidates for active surveillance, and if they are mutated, the patient should know that the risk of reclassification is higher. Then it's a decision with the patient. But I agree with you, we do not have strong data to deny active surveillance as an option to these patients. We have a couple of questions, actually. And the first one is there any place for genetic testing for patients with oligorecurrent disease after radical prostatectomy? And I actually presented some data, but these are preliminary data on the role of genetic testing in men receiving salvage therapies, and these were metastasis-directed therapies within the context of the OREOL and the STORM trials, so trials aimed at treating the recurrence in the oligorecurrence setting. So these data are prospective data, but it is a retrospective analysis. I will be careful in translating it directly into the clinical practice. Probably in the future, we will see a role for testing also in this setting, but nowadays I think it is too preliminary, and we should remember that the number of patients was relatively small in these cohorts. And I have a question for Emmanuel related in this setting to what is the ideal timing for testing our patients. Should we already test these patients at the first sign of metastasis? And you actually differentiated between what is done in research and what is currently done in clinical practice. So do you think also for research purposes it makes sense to have a biopsy of the metastatic lesion? We can go for salvage lymphadenectomies. Should we test the presence of mutations in this setting as well?
So remember, for metastatic patients, most of the time you will give ADT plus abiraterone up front. And then when that patient progresses, they will become immediately eligible for olaparib as a monotherapy, according to the existing FDA and EMA indication. And because of that, I'd like to think at least one step ahead of myself. I usually get the somatic and germline testing for all metastatic patients for that purpose. The purpose being when they develop that first line MCRPC. Of course, if they have ADT alone, which is not recommended, but sometimes we are forced to do that if there's other comorbidities or patient preference, then the patient will not be eligible for, olaparib monotherapy until they have failed one AR targeting agent. But the short answer is germline testing, yes, every single metastatic patient, because 12% of them will have a mutation. And somatic testing, I do it in order to plan for the next step.
Thank you. And the next question we have from our audience is related to the age limit for the use of PARP inhibitors in patients with metastatic castration-resistant disease. Nicola, you presented us some data. What about the inclusion or exclusion criteria of the studies you presented? Was there an age limit, and how should we deal with our patients in clinical practice?
Well, as usual, there is an age limit, but as usual, age limit in clinic is irrelevant. What is, to be provocative, I say this that way. What is relevant is your expected life expectancy, which is directly linked to your comorbidities. If you have 60 years of age with a completely non-functional heart, lung, liver, brain, etc., your life expectancy for the same disease at the same stage is far lower compared to a very healthy 85-year-old man. So clearly, there is no per se age limit. In the labeling, there is no age limit. It's purely a balance between side effects, toxicity, and initial comorbidities. Clearly, we should definitely forget age. Age per se is useless. It's part of the individual life expectancy. We can give cabazitaxel, a quite toxic drug, up to 80 to 85 years old. I'm not saying to every man 85 years old, but for a very fit one, we can receive and tolerate that. Why should it be different with PARP? No, absolutely no reason. I don't know if Emmanuel agrees with this, but age limit per se is irrelevant.
Yeah, I wanted to say that for me, the hemoglobin level is very important because many of these patients already have bone metastases. Some of them have received the chemotherapy before. And in my personal experience, about 10 to 15% of patients receiving just olaparib by itself, they develop grade 3 anemia. So that means they need a blood transfusion. So for me, rather than looking at age, I look at, of course, life expectancy, and then I look at the bone marrow function. And if I have a gentleman with hemoglobin, 10 or 11 grams per deciliter, I worry about that patient because he's going to drop it down to 7. And I don't want to have to impair his quality of life by giving him transfusions every 3-4 weeks.
Agree. But then it's again, I fully agree. And that is again part of the discussion about the risk-benefit balance, if there is a valid option, because if you are that way, you also have the issue of the other drugs that are also toxic for the blood. Absolutely true.
Thank you. So we have 2 questions which are in a way related. One is if we should consider germline mutation or somatic mutation or somatic mutation only. And I think here basically the answer is that we can use both of them, and if a patient has a somatic mutation, as we should go back and test also germline mutation. Do you have any comments, Emmanuel, on this?
I think it's best to do both whenever you can. If you do a germline only, you will miss 50% of the HRR mutations, so you will get only about 12% instead of 25%. And conversely, the study that you showed, Giorgio, I think 20% seems high, but at least 5% of the time, if you do a somatic only panel, you will miss a germline mutation for many reasons. And you can miss mutations that are actionable, including BRCA2 and also mismatch repair, MSH2, etc. So I think it's important to do both if possible. And the germline is the easy one. But whenever you do somatic, you should never rely on the somatic to infer the germline, because it's only going to be an inference, and then you need to prove it too.
And this has also consequences for genetic counseling. We should not forget it, and it has serious consequences. So, Nicola, please.
Yeah, two things. The first point I wanted to make, you made it. By law, in many countries, if you go for germline testing, it must be done through a geneticist. To be practical, a geneticist in my hospital, the waiting list is more than a year. That's real life. I think that the awful thing of all that is just to think and to do it. It seems to be very easy in some places. Emmanuel and you seems to have very easy access to all these tests. I'm absolutely sure that's not the case for most of us, where there are two issues. The first is the cost, which is far from being trivial. And even if you check everything, roughly 50% of them are tested for nothing. There's a cost issue. And there's also a test issue. Which tests, how available are they? How reproducible are they? Once again, validated tests, there are not so many, at least in Europe. So I think this is an absolutely major point to check. Even if you want to do it, it's not so easy often to have it. Not to discuss the cost once again, which is different.
Thank you. We have a couple of final questions actually on a similar topic. So when we have a metastatic patient, which tissue should we use? Should we go for the radical prostatectomy specimen? And Nicola, you showed us that maybe 5 or 7 years can be cut off to, let's say, use this specimen for genetic testing. Should we perform a new prostate biopsy if the prostate is there? Should we rely on the biopsy of the metastasis? We saw that some guidelines, for example, the NCCN, are currently recommending to prefer the biopsy of the metastasis, but I would like to know what is your opinion.
Well, in an ideal world where cost should not be an issue, I would start checking the specimen I have in bank. If I have the result with the specimen, I'm happy. But you need also to realize that you might have a result from a specimen that was taken 10 years ago, 15 years ago, that might tell you about germline, but nothing to do about somatic, because the mutation might occur later on. So if it would be negative, then I would go for biopsy anywhere outside the bone, provided it's easy to access. And if you have nodes, if you have different metastases, that's easy to access. But the bone clearly is the last thing I want to biopsy. I'm more and more interested with cell-free DNA that are very easy and very patient-friendly. The issue is the false positive rate, which clearly seems to increase with the advanced age. So in an ideal world, data bank, then blood, and if it's positive, confirm with tissue testing. If I would be a patient, I would love to go that way, through this pathway, but it's not feasible because of the cost. So then do directly the tissue biopsy and you get the result, I guess.
Thank you. And which is the pathway in the US, Emmanuel?
Well, that there's a secret. It's a dirty little secret that, bone biopsies are very hard to do. Even the people that claim they can do them well, they fake their results. They say we have 60% yield. That's nonsense. The yield is going to be 25, 30%. And even if you have a yield, the first thing the pathologist does is he decalcifies the bone. And if you are going to be using that for NGS, you have to call your pathologist ahead of time and you tell him, don't decalcify it or do the light decalcification, because that denatures all the DNA and RNA. So I agree with Nicolas. If I have a radical prostatectomy or biopsy within 5 years, that's my first choice. If not, I prefer lymph node or liver. I biopsy all my liver metastases because I want to make sure it's not small cell neuroendocrine anyway. So there's a clinical indication to biopsy liver, I would say always. And then bone, I would do bone last after I tried circulating tumor DNA first.
Thank you very much. And with this, I think we can close our session today. It was a real pleasure to be here with you, and thank you for your contribution.
Grazie mille, merci beaucoup.
Bye bye. À bientôt.